to the next topic, which is exploring surgical avenues for sleep apnea, the tongue base and hypopharynx, by Dr. John Lo Ming Rin. Dr. John is a consultant at Chye General Hospital, and he's currently doing a sleep medicine fellowship in Taiwan. He seeks to develop transoral robotic surgery program for sleep apnea at Chye General Hospital, and he has also been involved in several cases of hypoglossal nerve implantation program in UMHealth. So very warm welcome to Dr. John. The floor is yours. Thanks.
Thank you, Prof. Jeyanthi. So thanks for inviting me to speak this morning. Thinking back I graduated from National University of Singapore, and back in school, we used to have this NUS games every few years. And looking back, actually, University of Malaya and University of Singapore, we all came from the same historical colleges. And I'd like to see you guys as my cousins or from across the causeway. So I think webinars like this can help to build our sharing of knowledge and our friendship between our countries and between our institutions. So thank you very much for inviting me. As a starter, I just want to introduce the healthcare system in Singapore for those who are not so familiar, at least in the public side. I come from UMHealth, which is comprised of Changi General Hospital, as well as Singapore General Hospital, Sengkang Hospital, and our related specialist centers. Across the country, within the public healthcare system, we have different ENT specialists covering all the major hospitals. So I would say that our sleep surgery practice is actually pretty well developed. Over at SGH, Prof. To Song Toy and Dr. Sean Low, I would consider my mentors, which I trained under them throughout my residency program. I work in Changi Hospital, which is a 1,000-bedder hospital near the airport with 6 beds for sleep studies. And we perform outpatient studies with a WatchPad 200. And like what Julius has set up in we have a multidisciplinary clinic, a multidisciplinary sleep service, which is currently headed by the respiratory medicine department, but the headship rotates across the different subspecialties and with contributions from psychiatry as well as neurology. So on to my topic proper, I'll just outline why we need to address the tongue, where's the problem, identifying the site of the problem, and some of our surgical options. So why bother about the tongue? I think ENT surgeons, we have a little bit of a bad reputation about sleep surgery. In the past, sleep surgery was all about the palate alone. And what happens is if we only target the palate and we do not realize and do not identify other levels of obstruction, we can lead to failure. So the palatal procedures were developed in 1981, were popularized in 1981 by Fujita. And several years later, Fujita himself realized that the tongue has a role to play. And he described the Fujita classification, in which type 1 would be a patient like what Julius described with just palatal obstruction. But in patients with type 2 obstruction, there was both palatal and tongue-based obstruction. And type 3, which is less common, would be isolated tongue-based obstruction. Later, Powell and Riley from Stanford suggested that up to 93% of patients had multi-level obstruction. And in analysis by Chye et al., he described that if we only treated the palate, we only had about 40% surgical success rate. And I think with among the ENT community, a lot of people gave up doing sleep surgery if we only did palatal surgery. For the head and neck surgeons and anatomists in the room, my topic is hypopharyngeal surgery, but in OSA literature, we actually misuse the term hypopharynx. Hypopharynx, in an anatomical sense, it's really a part of the back of the throat when it goes down into the piriform fossa, posterior pharyngeal wall, and the postcricoid space. This is the part of the pharynx that's involved in swallowing and not really in breathing. But in sleep apnea, we kind of misuse the term to rather describe the lower portion of the pharynx, which includes the oropharynx, the tongue base, and the lingual tonsils, and even part of the laryngeal structures, including the epiglottis. So when in this talk, when I use the word hypopharynx, I'll be using the OSA definition, not the anatomical definition. So first of all, we need to evaluate, is the hypopharynx a problem? And what Julia showed were awake scopes. And with awake scopes, we can see static obstruction. For example, this patient with really large lingual tonsils, whether they're awake or asleep, it is enlarged. But sometimes things are dynamic. When you are awake right now, no one is snoring. No one should be snoring. So snoring is a problem only when people are sleeping. And so evaluating them when they are asleep can help to uncover certain obstruction that may not be so noticeable in the clinic. And I do use drug-induced sleep endoscopy, particularly using propofol sedation in the operating room to look out for tongue base and epiglottis collapse and dynamic palatal collapse. So you can see in this patient, he's a young guy with normal BMI, in fact, slightly underweight. And you can see that his tongue is dropping all the way back. And with the jaw thrust, everything opens up. And once he falls back asleep and the jaw thrust is released, everything collapses again. So in this patient, we can see it's AP tongue base collapse. But before we blame the tongue base proper, this is the same patient, and we can see that he has a small jaw with open mouth posture. Opening the mouth reduces the distance between the geniohyoid distance, and it causes the tongue base to fall back. And you can see the effect of opening and closing the mouth. And in his case, even though the site of obstruction is tongue base, it is due to a small skeletal box. And from a severe sleep apnea case, I sent him to my dental colleagues, oral maxillofacial colleagues. He had a maxillomandibular advancement and achieved surgical cure with a maxillomandibular advancement. The other side of obstruction that is very well seen or very particularly useful to be seen on sleep endoscopy is epiglottic collapse. So it can occur in an AP sort of a trapdoor pattern, a side-to-side book pattern. And for those who haven't seen a DICE before, this video shows what goes on in the operating room with the anesthesia in the background. And you can start to hear the snoring come on at the end. As the epiglottis is indrawn, you can actually hear the vibrations and the snoring, and you can actually hear the monitor desaturating a little bit. And about 12.5% of patients have primary isolated epiglottic collapse. It's not so common. Most of the epiglottic collapse come on as part of multi-level obstruction. So my approach in evaluating a patient for tongue base or an hypopharyngeal obstruction would be firstly to make sure that the CPAP was optimally fitted and titrated. If it was just left on auto titration, I may consider sending them for a titration study. I discuss non-surgical options first, including weight management, myofunctional therapy, and oral appliances. And then I can discuss surgical options with them based on awake and asleep evaluation. So talking about the individual levels, I'll start with epiglottic obstruction. There are various surgeries that have been described. I usually perform a partial epiglotectomy with a little bit of an epiglottopexy sometimes. There are many techniques of doing this. I tend to prefer using either a flex retractor or a Fay-Kesterbauer or FK retractor. And I find that this gives me a good enough view, either transorally or with an endoscope. And I find that with extended tip monopolar diatomy, I am able to reach the epiglottis and trim it off pretty quickly. Later, I'll show a video. But there can be other techniques using either a laryngoscope, like a Lindholm laryngoscope, or using lasers to excise the epiglottis. In doing so, there is an epiglottic artery that comes from close to the base lateral aspect of the epiglottis and near the epiglottic fold. So I tend to stay away from this area and really just trim the tip or make a V shape such that there's space in the middle for the air to go through. So the evidence for doing epiglottic surgeries is quite, there are only a few case reports and case series because it's not that common to have isolated epiglottic collapse. But in a series by Gold, he had an AHI reduction of 45 to 14, and Katafumo described a series of patients who had failed UPPP, and 11.5 patients who had failed UPPP had untreated epiglottic collapse, and upon treating the epiglottis, their AHI reduced from a mean of 42 to 8. Personally, I've had only one case of isolated epiglottic collapse. This was his sleep endoscopy video, and you can see his epiglottis kind of folding in like a trapdoor. And because it is a trapdoor pattern of collapse, whenever he tried CPAP, the CPAP actually worsens this trapdoor effect. CPAP works very well for side-to-side collapse, but if it's a toilet lid or trapdoor and you blow air, it kind of pushes the epiglottis even more. So it tends to kept waking up with the CPAP with a choking sensation. And he also had sleep initiation and maintenance insomnia as a result of OSA. So in his case, without touching the palate, I did a partial epiglotectomy and a coblation tongue channeling. And his AHI went from 34 to 6.8 with improvement in sleep efficiency. His insomnia resolved and he was discharged from psychiatry and did very well with a very targeted surgery. For tongue bulk, we can consider coblation or radiofrequency tongue channeling, or for more invasive options would include midline glossectomy or SMILE procedure, which is a submucosal, minimally invasive lingual excision. Personally, I do not practice the lower two procedures because of a higher risk of morbidity. In Friedman's series, there was a higher risk of complications when he did a SMILE compared to radiofrequency procedures. And he had 2 cases, which were 2 out of 46 cases that had bleeding, which was stopped intraorally, and another 2 out of 46 cases that required external ligation of the lingual artery, and 1 case with permanent hypoglossal palsy. So even though it is an effective technique, I feel that it's a bit higher risk, and I tend to trend towards doing a more minimally invasive approach. This is one of my patients undergoing a coblation tongue channeling. Basically, I put 3 to 4 points in the midline and 3 to 4 points at the lateral edges of the tongue. The series by Friedman shows that there's an improvement in the success rate for Friedman stages 2 and 3, meaning in patients who originally, if we only did a palatal surgery alone, the addition of radiofrequency to the tongue improves success rate from about 40% to 55.1%. And in stage 3 patients, 8% success rate to 33% success rate. Stuart McKay from Wollongong in Australia described the coblation tongue channeling technique, in which he described the AHI reduction of 23.1 to 5.6 when combined with UP3. So for large lingual tonsils, I perform coblation lingual tonsillectomy, and I am embarking on my fellowship to train in robotic surgery. Other people have described using a CO2 laser, and Dr. Yasin Bhagat has described a hybrid between coblation and using a robot, and what he described as a RoboCop technique. I again tend to just use a tonsil gag or a FK retractor, but I use a shorter blade than a regular tonsil setup, and just for the tip to sit around the circumvallate papillae. I asked the anesthetist to use a nasal intubation so the tube doesn't get in the way, and I use a 30-degree scope. And this is an intraoperative video. And you can see I marked out the midline because the paired lingual arteries come in from the side. So if you stay close to the midline, it's fine. If the tongue is very bulky, I may excise the posterior midline part of the tongue slightly. And I'm just going to speed up the video for the interest of time. Starting from the midline, I would slowly just shave off the lingual tonsils from both sides. And this is what it looks like towards the end. And now we can actually see the base of the epiglottis, where at the start we could only see the tip of the epiglottis. And for this case, I moved on to trim the epiglottis with just an extended needle tip monopolar cautery. And with adequate retraction and good access, the epiglotectomy is fairly quick, straightforward procedure. But in certain cases, especially in OSA cases where they have skeletal restriction, access may be more limited. So compared to doing a coblation or endoscopic approach, a transoral robotic approach gives a far better view in 3 dimensions. This video is not my case, it's from one of my mentors, but you can see super clear, high definition. The robot has a 3D goggles, so we can actually appreciate the depth and we can appreciate the tissue planes a lot better, and can lead to quicker, faster, and less bloody dissection. Especially, I find the robotic approach to be useful for larger 3+ or 4+ tonsils. I'll just skip to the end of the video to show what it looks like. We remove each half separately, and this is the final transection of the left half, and this is the view after removal of both palatine tonsils and lingual tonsils. So this is a case that I did coblation lingual tonsillectomy. You can see, because the view is a little bit more difficult, there's some residual lymphoid tissue, but it tends to involute over time. And in this patient in which I did tonsillectomy, UPPP, coblation lingual tonsillectomy, he had good surgical success, not a total cure, still had a bit of residual AHI of 8.6, but his symptoms markedly improved. And you can see everything heals up pretty nicely from the palatal standpoint. So outcomes of lingual tonsillectomy, again, there's very little literature on lingual tonsillectomy alone. Most of the literature is pooled together with tonsillectomy and uvulo-palatopharyngoplasty. But in a series by Moderator et al., just doing lingual tonsillectomy in properly selected patients, there was a mean AHI reduction from 27 to 6. When paired with palatal surgery, there's an average AHI reduction from 42 to 21. Even though it is an effective surgery, there was a case a couple of years ago in Singapore that kind of shook the community, in which a patient actually passed away after doing transoral surgery due to bleeding, while the patient was out of hospital, and he had a collapse and actually demised. So for a young patient who had sleep apnea, I think this is difficult to accept. You know, if we were doing a tongue-based surgery for cancer and a patient only had 1 or 2 years to live if they didn't do the surgery, and there was a poor outcome, it may be a little bit more acceptable. But for someone in the peak of their life with sleep apnea, I think we do need to be cautious. And other than bleeding and airway compromise, which is a very dreaded complication, I've had 2 patients with prolonged change in taste or global sensation, but thankfully most of them had improvement in their taste sensation after 6 months to a year. Dysphagia, once we are touching the epiglottis and tongue base, I even had one of my own ENT colleagues who went for a surgery of the epiglottis and had about 6 months of dysphagia, but thankfully that has resolved. So before embarking on any tongue-based surgery, really, I would counsel and evaluate for all other options, including non-surgical options. Last part of the talk is that it's not always anatomical obstruction, but sometimes it's muscle tone rather than physical blockage. And we can evaluate for poor muscle tone with different instruments, such as the Iowa Oral Performance Instrument, or IOPI, or a group from Spain actually described the tongue digital spoon as an analog, just seeing how much force the tongue can generate in anterior-posterior direction. And in patients where there is poor muscle tone, rather than excising muscle, I feel we should be encouraging training of the muscle, especially the muscles of the tongue, and synergistically that can help tense the palate as well. In this case series, in this meta-analysis, Kamako et al. Described a 50% reduction in AHI in children and 62% in adults. Within UMHealth, we have these brochures as well as this YouTube video. I won't play the whole video, but you can search for it on YouTube to learn about it and practice along if you or your loved ones may have sleep apnea or snoring. And I think it's a great starting point. There's almost no risk. However, for the hundreds of patients who are told to go back and watch this video, I've only had a handful that actually went ahead to do it. And let me just present one case that did extremely well. This was a 65-year-old lady, non-obese, slightly retronathic, favorable anatomy. There was no large tonsils, slight turbinate hypertrophy. She had moderate OSA, but She couldn't tolerate CPAP, didn't want to go for any surgery. And well, the only thing I counseled her was to that she accepted was to try myofunctional therapy. And she was really diligent. She followed the videos, did it every day, 10 minutes a day for 1 year. And she had a good AHI reduction from 26.7, a moderate case, to a mild 9.9. And with actually, even though I told her to lose weight, she actually didn't lose weight. So it wasn't a contribution of weight loss. It was just on the myofunctional therapy alone. And also, it wasn't there was not much change in sleep position, so it wasn't effect of positional therapy. So myofunctional therapy does work, but it needs a lot of motivation. It needs patient to use it every single day. And finally, for muscle tone, if it's a problem of atonia, and if they can't be consistent with myofunctional therapy, hypoglossal nerve stimulation may be a appropriate tool. It's an upcoming and exciting part of our surgical armamentarium. We would consider it in patients with smaller tonsils, favorable kind of collapse, and certain comorbids. If they have comorbid untreated insomnia or other medical comorbidities, we'll tend to avoid it. So far, it's indicated in adults 18 years and above, or teens with Down syndrome. Initial FDA approval was for patients with BMI of 32, but now recently there's been an expanded indication of a BMI of up to 40 and an AHI of up to 100. We do need to do a sleep endoscopy before considering them for Inspire implant to make sure they don't have a certain pattern of collapse. There are other brands in the market, Imtera and Nixoa, but so far they have not yet available in Singapore, so I have no experience with them. This is how we perform the procedure: incisions in the neck and the chest. We dissect the digastric muscle inferiorly and the digastric muscle and the mylohyoid muscle would be retracted anteriorly to reveal the hypoglossal nerve. And this is what the nerve looks like, and we identify the different branching patterns. It's a little bit more complicated than just finding the nerve. We have to find the nerves that affect the protrusor muscles of the tongue and exclude the retractor muscles of the tongue. And then we cuff in an electrode under microscopic vision. I'm just going to fast forward this, and the cuff sits over the nerve, and we plug in the stimulator lead into the generator, implantable pulse generator, and another lead between the external and internal intercostal muscles of the pleura. That's the sense lead, and it goes under the chest wall, just above the pec major muscle, similar to a pacemaker. And this was a video of one of our cases.
Oh man!
And this is, of course, at maximal stimulation in the operating theater. So the patient would come back for a titration such that we can adjust the voltage to be sufficient to protrude the tongue, but not too much. It shouldn't fly out of the mouth like this every single night. So far, pretty good results internationally. Locally, Dr. Sean Low will be publishing his data soon. So in summary, for the tongue base and hypopharynx, I would recommend thorough evaluation, both awake and asleep. Before thinking about anatomical obstruction, consider other causes of tongue-based collapse, such as skeletal restriction and poor muscle tone. Because of the high risk of tongue-based surgery, I would consider and discuss all non-surgical options, especially to make sure that the CPAP is well titrated. And if they are CPAP failures with appropriate understanding and consent, I would consider surgical management directed both at the patient's anatomy and physiology. Thank you.
Thank you, Dr. John, for that really comprehensive talk today. Any questions from the floor? I have a quick question. You know, your video on your epiglottis, what do you use to remove part of your epiglottis?
Yeah, so
Laser or?
I just use a extended tip needle point monopolar diatomy. So Yeah, I can share the photo again. I find that's the quickest way, but of course, I tend to dial down the energy settings because I don't want to cause too much edema post-operatively. So I just use about 12 watts on a belly lap monopolar. Either with a specialist,
Okay.
this tool is my diatomy tool.
Okay, thank you. Okay, I think because we're running over time, thank you so much, Dr. John, who's talking from Changi General Hospital. Thank you for joining us today. And yes, definitely collaboration between Singapore and University of Malaya is something we look forward to. So this brings us to the end of our webinar. So the Department of ENT, in conjunction with World Sleep Day, encourages everyone to practice good sleep hygiene to promote overall well-being. Thank you very much, everyone. Have a great week.
Thank you.